Hello friends, this is Dr. Nasik Bal. Welcome to another video of Alaa Notes, and in this video we are going to discuss pre-eclampsia. So the first question is pregnant lady with blurred vision and headache and BP 120 and 170 by I don't know what is the other value. So the question asks about what to do. So here in this question there is a severe sign of pre-eclampsia given, so the answer should be delivery. So the answer is stabilize the patient, give magnesium sulfate and deliver the patient. So the next question is about magnesium toxicity. What to do in magnesium toxicity? You just have to stop the magnesium sulfate. So the other question asks about primary gravida 32 weeks or 32 years, I don't know, came with mild headache and no abdominal pain, no visual disturbance, blood pressure is 150/90, urine analysis 3 plus protein. So what's the appropriate management? So here in this question I am assuming that this is 32 weeks of gestational age, so this is less than 34 weeks, so we have to admit and observe the patient. So if it would have been more than 34 weeks, then still we would admit the patient and observe, and if it would have been more than 37 weeks, then we would go for prompt delivery. So pregnant female 32 gestational age, BP 150/90, protein urea is 3 positive. So what's next? Just admit and observe. Again, this is less than 34 weeks, so you have to observe and admit until 37 weeks. So next question is pregnant 10 weeks of gestational age with hypertension, never went to doctor before. So this is chronic hypertension. What is the complication? So the complication of chronic hypertension can be preeclampsia. So the other question is pregnant present with 38 weeks in labor, BP 150/90, elevated protein creatine ratio is elevated, so this is preeclampsia. So this is a typical case of preeclampsia. The other question is 39-week gestational age woman with protein urea BP 140/90, your action would be induced labor. The other question is pregnant with preeclampsia, mild, BP is 140/40, I don't know, it should be 90, with abdominal pain. So this is a severe feature of preeclampsia. Platelet and I don't know, this is urine or uric acid is not given. What indicates severity? So abdominal pain, as I have discussed earlier, is an indication of severe features of preeclampsia. So here the severity is abdominal pain. The other question is case of preeclampsia, patient is on labetalol, she is 32 weeks pregnant, fundal height is 28. What will commonly occur if IUGR is suspected? Then I have discussed this earlier, oligohydramnios. If the question asks IUGR, search for oligohydramnios. If there is oligohydramnios in question, search for IUGR. So IUGR, which one of the following can be caused? Here is the question, oligohydramnios. So the other question asked about there were two cases of preeclampsia. One was 34 weeks, another was 32 weeks and 34 weeks. Both has hypertension and protein urea. What will be the management? So in this question there are no signs of severe features given, so we just would admit the patient and observe. So here is the given delivery is the only cure for preeclampsia. Patients with preeclampsia without severe features are induced after 37 weeks. As I have discussed this earlier, you will wait for 37 weeks of gestational age if there are no severe features present. Before this, the patient is usually hospitalized and monitored carefully for the development of worsening preeclampsia or complications of preeclampsia, and the immature fetus is treated with expectant management like corticosteroids to accelerate lung maturity. In patients with preeclampsia with severe features, induction of delivery should be considered at 34 weeks. We have discussed this earlier. In these cases, the severity of disease must be weighed against the risk. So here is that question again. Pregnant, 34 weeks of gestational age, preeclampsia, BP 170/90. There are no severe features mentioned here, so we will stabilize the patient, give magnesium sulfate and admit. There is no the delivery is not mentioned over here, so we would just admit the patient and observe till 37 weeks. So the next question is preeclampsia, what drug to give to prevent convulsions? Of course, magnesium sulfate. This is an indication of magnesium sulfate to prevent convulsions. Pregnant, 34 weeks gestational age, vaginal bleed. So here is another severe feature. Open cervix is 6 centimeter dilated. Preeclampsia. So fetal bradycardia. This is also a severe feature of preeclampsia. So the answer would be whatever would be the gestational age, give magnesium sulfate and immediately deliver the baby. So pregnant in 32 weeks with preeclampsia, what to do? Admit or to observe. Again, there is 32 weeks mentioned over here, so we would just admit the patient, and there are no severe features mentioned in this question, so we would observe. 34-week preeclampsia patient came with epigastric pain. This is severe feature, headache, blurry vision. These are all severe features. No non-stress test is reassuring management, magnesium sulfate and delivery, immediate delivery in this case. So magnesium sulfate is given to the patient of hypertension in pregnancy. So why it is given to prevent attack of eclampsia, to prevent seizures. That's why magnesium sulfate is given. We have discussed this earlier as well. Pregnant female, now BP 140/90, platelets are 90. This is a severe feature. History of previous severe preeclampsia. This is also an indication. What indication here of severe preeclampsia? So low platelets are here the indication of severe preeclampsia. So the other question is pregnant pregnant lady complain of severe abdominal pain, uterine contractions, severe features are mentioned. She was given 6 milligram of magnesium sulfate. So here this is important point. And then the contractions become normal, then decreased to dose of, then the magnesium sulfate was decreased to 4 milligram. Then patient complained of shortness of breath, SOB. This is magnesium sulfate toxicity, so we would stop the magnesium sulfate and give calcium gluconate. So the other question asks about the case of preeclampsia with very low platelet count and high urea. What indicators that is preeclampsia low? These very low platelet count, this is a severe feature, so this is the answer is low platelet count. Pregnant lady with seizures, get 6 milligram of magnesium sulfate was given, then decreased to 4 milligram. There is absent deep tendon reflex. This is also magnesium toxicity. Stop magnesium sulfate and then give calcium gluconate. This is the answer. Patient on oxytocin and magnesium sulfate. Okay, so preeclampsia is also there. Her CTG cardiotocography is absent variability. What's the cause? Magnesium sulfate toxicity. As I have mentioned in my previous lecture, what are the signs and symptoms of magnesium sulfate toxicity? This is one of that, absence of variability on CTG. So the other question is mother with preeclampsia was given oxytocin and magnesium sulfate. Now CTG shows non-reactive. This is also magnesium sulfate toxicity. So we would stop immediately magnesium sulfate and give calcium gluconate. So the next question is patient at 32 weeks of gestational age presented with seizures and high blood pressure. Okay, there are seizures, these are severe features. What is the next appropriate step? There was no mention, there was no medication for seizure in the answer, so we will give magnesium sulfate. So the question in this question they are asking about the patient 32 weeks of gestational age, she is having high blood pressure and seizure. There were no anticonvulsants given in the choices, so the magnesium sulfate would be the right choice in this case. Why administering magnesium sulfate in case of preeclampsia? We have discussed this earlier, to prevent seizures. Okay, so patient with severe preeclampsia, acute management of hypertension would be hydralazine. We would give hydralazine if there is severe preeclampsia and uncontrolled blood pressure. So GDM, gestational diabetes mellitus type F, I don't know what is this, with nephritis. So there is GDM with nephritis and controlled hypertension. Okay, she is pregnant now. What's the most complication will occur? Which complication will occur? So it will be preeclampsia. So gestational diabetes mellitus and nephritis can lead to preeclampsia. You should remember this. So pathophysiology of gestational diabetes mellitus, placental hormones like lactogen. Placental lactogen is the cause of gestational diabetes mellitus because it causes insulin resistance.